Well, it is not an easy journey for anyone. It's quite tough for both the patient, the family, the caregivers, and also for the oncologist. Each time you meet with the oncology patient who has been diagnosed with cancer, and you have to just understand what they are really aware of and how open they are to a discussion about their disease. Because I think it's mainly dependent on some sociological and psychological properties of that particular patient.
Everything related with treating human life and human biology can cause cancer because it's a genetic disease. It's basically because of the division control of a cell. And it's a part of growing, but when you cannot control proper division and growth, then it turns to cancer. So the environmental factors related to pollution, what you eat, especially the Western type lifestyle, less, physical activity, smoking, pollution, the market foods, unnatural eating habits, obesity. These are the things that may cause any type of cancer.
30 years ago in 1991, a small hospital welcomed its first patient in a district of Istanbul, Turkey. Acibadem was the name of that district. Today, Acibadem Healthcare Group is a global brand providing superior medical services in Istanbul, Ankara, Bursa, Eskişehir, Muğla, Kayseri, Adana, and Izmir. Through acquisitions, our footprint expanded to Macedonia, Bulgaria, the Netherlands, and Serbia. In 2012, Acibadem signed a joint partnership with IHH Healthcare, becoming a part of the world's second largest healthcare group. Today, IHH Group is operating with more than 15,000 beds and 65,000 employees. More than 5 million patients yearly visit Acibadem facilities located in 5 countries to meet all their needs.
Bine v-am regăsit la un nou episod de podcast BZI. Sunt iarăși eu, Viorela Dimici, gazda acestui podcast. Astăzi avem doi invitați care au făcut drum lung să ajungă în studioul nostru. Vorbim despre oncologia gastrointestinală cu doi specialiști de renume, Prof.Dr. Erman Aytaç și Prof.Dr. Leyla Özer. Sunt ambii doctori la clinica Acibadem și discutăm astăzi despre acest subiect și despre noile metode de tratament și inovații din acest domeniu. Este o onoare pentru noi că au ajuns astăzi la podcast BZI și putem să discutăm cu ei. So, hello, nice to meet you and welcome to our podcast, and thank you that you accepted to come here.
Thank you very much.
Thank you
for having us.
Let's start with my traditional question, because I'm asking every time my guests to describe themselves, because I think how you'll describe yourself will not do anybody else. So who is Prof.Dr. Erman Aytaç?
Okay, thank you for giving us the opportunity to be here. I'm professor of surgery at Acibadem Hospital. I'm chief of surgery there, and my main interest is gastrointestinal cancer, which are the cancers of the esophagus, stomach, large bowel, pancreas, liver, small bowel, and the anal area. So basically, we are trying to treat those disease with surgical techniques, including the classical techniques and the most advanced technique, including laparoscopy and robotic instruments. And I'm also one of the co-chairs of the gastrointestinal oncology unit with Professor Özer. And we are trying to approach and treat those patients in most advanced ways in our units.
So, thank you. Who is Prof.Dr. Leyla Özer?
Again, thank you for this kind invitation and this nice introduction. Well, I'm a professor of medical oncology, and I have been training on first internal medicine, and then afterwards I have trained on medical oncology area. Both training had been accomplished in Istanbul, in Turkey. And afterwards, I have been working in Acibadem Atakent Hospital with Professor Aytaç in Istanbul for long years. And for the last few years, I have been dealing more on gastrointestinal cancers, as Professor Aytaç has mentioned, but I'm dealing with all oncology cases indeed. But I'm trying to be more specialized on GI cancers.
Thank you. How did you choose this area? How did you choose medicine? How did you choose oncology?
It's a nice question. My decision to start medicine was after taking the results of our university examination. And I decided to study in medicine after finishing my high school, which is Kabataş High School, one of the prestigious high schools in Turkey. And I started my training in Cerrahpaşa Medical Faculty. And in early years, my interest in surgery increased. And during my studies as a student, I started to approach surgical teams. I voluntarily worked there in all the years, a couple of years. And I had the opportunity to start my residency for specialty in surgery at the same institution. And I was very lucky to train by one of the pioneers in laparoscopic surgery and abdominal surgery there. And I had the opportunity to have a training in Cleveland Clinic with the help of my prime mentor, Prof.Dr. Feza Remzi. And he gave me the opportunity to start as a research fellow there, and I had the opportunity to do the clinical fellowship. And I had the opportunity to work with all the pioneers of the gastrointestinal disease treatment. And then my interests become more and more for complex cases with gastrointestinal disorders. At the beginning, it was most likely for the inflammatory bowel disease, which are Crohn's and colitis. And then when I come back to my country, I had the opportunity to work with Professor Özer and others of colleagues, which are very experienced on cancer. And my experience with gastrointestinal treatment from surgical perspective was skewed to gastrointestinal cancers. And now we are treating our patients together, and we put our all knowledge and work on to create the unit specialized on gastrointestinal oncology, because all the years the knowledge is expanding on every field, and it's not easy to do everything in a certain level. So you should pick up one single topic and to know that topic in deep. And it is possible by choosing this, and it's possible to do this with a team itself. So this was my summary of journey, how I become a gastrointestinal oncological surgeon.
Some of somebody from your family also is from medical field, or you are the first one?
I'm not the first one, but not close, but a couple of my relatives was in medicine. I met most of them during my education in medicine, so I met some of them. I was already in medical school. They live in the United States, and some of them live in Turkey. But I decided to be doctor by myself without knowing them. So in the journey, I had the chance to meet with the other members.
How do you feel when you understand that because of you, people are living and you can save lives with what you do?
It's you realize it from my perspective during your residency. In medical school, it's much more, maybe the others have different feeling, but to me, during my residency, I try to understand that we are doing that serious job. Because in medical school, you see everything, and you start with the basic science, and you learn how the normal process of the systems. And then at the second half of the medical school, you learn the pathologies. and the pathological pathways. And it was much more, to me, was just trying to focus on the learning period. But end of the medical school, especially during the residency, you see much more patients. And when you see the patients whole, not only as a patient, as a human being, then it affects you deeply. Mm-hmm. And day by day, you do some, empathy and feel their problems, feel their, issues. And then you start to solve them. And majority of the people, of course, appreciate you. But some of them, it's not easy to handle, the human relations. But you also used to how to run the relations while doing the treatment. And it's a process. Mm-hmm. But mainly it starts for me in the residency, since your patient connection is much more higher.
So, Dr. Leyla, how did you choose this field?
Well, my journey, at least the story is not that much long, but it's very typical childhood, which starts with, I want to be a doctor from the very early periods of my childhood. I was not really thinking of any occupation. And regarding your question, whether there was anyone in the family who you would take the vision and see how it is like. There is no one in my family who was a doctor before me. So it was a surprising area for me from the very beginning. And I was a very ambitious student from the very beginning. And indeed, surprisingly, we graduated from the same high school, Kabataş High School, again, a distinguished high schools in Turkey, in Istanbul, but 5 years earlier than him, I guess. And afterwards, I was always just trying to become a doctor, but I was not really very clear about which profession which subspecialty I should choose. And it was more shaped during the medical student training. Again, I think the choice about being medical oncologist was not that much clear. I had some kind of pure humanistic intention. Sometimes it's funny for some people, but my main idea was to help as much as people as I could. So I tried to choose a profession that would cover more people, and it was internal medicine. Doctor. So after graduating from the medical school in Istanbul, again in Cerrahpaşa University, and I chose to become an internal medicine doctor over there, and I trained for 5 years again in Istanbul University. And afterwards, when I became an internal medicine specialist, I realized that, as Dr. Aytaç has mentioned, it is not easy to know everything. When you're an internal medicine doctor, you deal with every type of diseases. Heart failure, lung diseases, dyspeptic disorders, anything. So first you establish a diagnosis, and afterwards, but it is not easy to treat all people. Even though you're able to diagnose the disease, you should refer the patient to the doctor who is specialized in that area. And I discovered that this was not satisfying for me, and that I should choose a patient group where I can be more helpful. And of course, I would have more deep knowledge in that area. And in that part, while during my medical training as an internal medicine doctor, the area of oncology seemed to be very empathic area for me, and that I can really be keen on some patients and be really helpful for them. That's why my oncology training started in that period, and it was almost 3.5 years. And afterwards, when I became a medical oncologist, for the last 15 years, I have been working as a medical oncologist. I am just trying to accomplish my aim, which I had been just defined in my mind to be helpful to some people, if possible. But of course, oncology is not an area where you can have always success stories. Mm-hmm. And it's important, I think, to define what success is. Is it really curing or healing every patient? It's sometimes different. success in oncology is sometimes prolonging life. Sometimes it's increasing the quality of life. Sometimes giving more qualified period to that patient to share with the family, with the loved ones. So, of course, so my idea about helping patients shaped during this medical oncology training, and still I'm working, and still I define myself as a medical oncology student, because I think it's one of the areas of medicine which is developing very rapidly. Mm-hmm. I mean, we are trying to follow up some guidelines, the European guidelines, the American guidelines, and you know what? The guidelines change so rapidly. And if you are unable to read, for example, the specific guideline for 3 months, then you see that everything has completely changed. So I saw that it was a necessity to be specialized on something else in medical oncology area. And after the arrival of Professor Aytaç in the hospital, he was really keen on doing this complex gastrointestinal cancer patients. And so I saw that this area is a good place to be developed for myself, for both my medical education and also for helping the patients.
Also, because today we are speaking about gastrointestinal cancer, I think it's important to start on what includes this kind of cancer.
Well, it starts from mouth to the anus, I guess. So everything, I mean, when you start eating from the mouth, and so the cancers starting from that area, I mean, the mouth, the oral cavity, esophagus, stomach, small intestine, large bowel, and the rectum and the anus, and also the pancreas and liver. What did I forget? Please. So this is mainly what we mean with gastrointestinal or digestive cancers.
Mm-hmm. So digestive cancer and gastrointestinal is the same type of cancer.
Yeah.
It's similar, just called differently.
It's much more technical in gastrointestinal, say, when you say it's much more technical. Mm-hmm. Digestive is more...
It's easy to pronounce digestive cancers. So
it's everything in related with digestion.
What are the risks and also the symptoms of this kind of cancer? Anyway, in general, cancer, it's not very easy to see at an early etap, but maybe there are some symptoms or risks that people can be attentive to.
Yeah, the risks are huge. If I had something missing, Professor Özer can complete. Everything related with treating human life and human biology can cause cancer because it's a genetic disease. It's basically because of the division control of a cell. And it's a part of growing. But when you cannot control proper division and growth, then it turns to cancer. So the environmental factors related to pollution, what you eat, especially the Western type lifestyle, less, physical activity, smoking, pollution, the market foods, unnatural eating habits, obesity. These are the things that may cause any type of cancer. Stress. And there are some genetic familial disorders can cause cancer, some familial polyposis syndromes, familial gastric cancers, that type of general risk factors. The symptoms are actually everything related with digestion again. Blood in the stool, abdominal pain, weight loss, bloating, change in the bowel habits. So these are the general symptoms that can associated with any type of digestive cancers. In this manner, we are actually trying to focus on to protect ourselves, which is possible. You cannot change your genetic, but you can change your eating habits. You can do more exercise. You can prevent from smoking and obesity. And there are some sort of screening tests for gastric cancer. So from ourselves, in our unit, we are also trying not to treat gastric cancer. We're also trying to create an awareness in the society regarding how can they prevent from it. We are lucky for colon and rectal cancer. There's a screening programs in all over the world. For if you are older than 45 years old, which was 50 before, but now it's 45, you can do colonoscopy, which is the gold standard test to diagnose and prevent. Then you can reduce the risk of having colorectal cancer, because majority of the colorectal cancers develop from the polyps. When you remove the polyps, then you don't get cancer. But other organs is not easy. In especially the Asian countries, there's a screening programs for gastric cancer in addition to colon cancers. Unfortunately, we don't have it. From our perspective, we need it, because now the lifestyles and the eating habits all over the world change, because everyone can eat everything, because the modern life made everything possible. So from my perspective, my personal, not is a scientific view, but my personal perspective, as European countries also requires screening programs for gastric cancer. For other types of cancer, there is no screening program for pancreas. There is no screening for liver, as far as I know.
Just for those with chronic hepatitis,
maybe.
They are on regular follow-up for liver cancers by the gastroenterology department. But the rest, as you had mentioned, there is no routine screening program. Of course, you summarized the whole cancer meaning, but indeed, we should emphasize that I think cancer is a genetic disorder, totally. But only less than 5% of the cases are hereditary, transmitted from the parents to the child. The rest, so 95%, are due to some changes in our genes, which control the cancer process. There are some tumor suppressor genes, and there are some tumor promoting genes, and there is always a balance in between them. And due to some environmental causes that we are exposed to during our whole lives, we have some mutations in our genes that where the oncogenic genes win the race. And the risks Dr. Aytaç has already mentioned. And because most of the time the patients are asking, why this happened to me? I'm trying to eat healthy. I'm doing sports. For the moment, we are really not able to explain what really caused that change in that particular gene. But at least we are able to detect which gene is the driver gene in some of the cases. And I think the most important development in treatment of cancer patients is to be able to develop some targeted therapies which try to act on these tumor driver genes. And these are areas where cancer treatment is very successful. But of course, it's not only one specific gene most of the time which is responsible from the appearance of a cancer in that patient. It is a multi-step procedure, and it is not only related with the genes, it's also about the tumor microenvironment, your immune system involved in fighting with the cancer. So there are many factors, and but fortunately during the last decade, the improvement in cancer care has been really rapidly progressing. And I think this is a very good, promising area for many cancer patients.
What inspired you to open a new digestive oncology center, and what sets it apart from other facilities?
So, as I mentioned at the beginning of the conversation, the knowledge about cancer is growing very fast, and it's not possible to know everything. So you need a focused team for a specific sort of problem to sort it out. So we started with this motivation to create our gastrointestinal oncology unit. We come together, we already was doing majority of the things together, but now we engage more and focused on trying to solve the problem of the patients with gastrointestinal disorder. So it was already our strong part, and we started to focus more and more day by day, not only for only oncology and surgery. It involves a multidisciplinary team. You need a very good pathology team to diagnose. You need a very good radiology team to see the images and, to express the stage of the disease at the beginning, and also evaluate the success or failure of your treatment during the course of treatment. So you need a genetician, you need a nuclear medicine doctor, and you also need the gastroenterologist. So it requires more than one or two branches. And to create new treatment options, you need more inputs from all over the aspect of the professional fields. So this would give us the opportunity to improve the quality of the treatment and to create new treatment possibilities. It's not possible when you do it in a single branch or single doctor. So to change the practice, to do new innovations, you definitely need a specific team focusing on a certain topic.
Mm-hmm. How does your team approach patient care, and particularly for those dealing with complex digestive issues?
Well, I must emphasize that all oncology patients need a holistic care from the very beginning, from the very diagnostic process to the, progression of the disease and maybe the latest time periods of life. But I think digestive cancer patients do really need a more sophisticated approach, because they are patients who are unable to eat, they have loss of appetite, they lose weight, they have some problems with bowel habits. Sometimes they have obstructions, sometimes they have diarrhea due to the drugs that you give or due to the radiation or due to the surgery, many causes. So they are really complicated, not only due to the disease, but also the treatment that you administer to those patients. So as Professor Aytaç has mentioned, every team, every unit is very important. The nutritionist, the gastroenterologist, the psychologist, psychiatrist, all of these specialties, apart from the medical oncologist, radiation oncologist, surgeon, and the other departments, it's really important to have these units included in this digestive cancer patient care. Our aim was to provide this holistic approach for the digestive cancer patients.
What types of cancer can be treated at Acibadem?
Well, we admit every type of cancer patients, but we are a university hospital in Atakent Hospital, so we are mainly dealing with very complicated cases who have maybe fed up with their all available standard treatment protocols, some in need of really complex surgical interventions. But of course, every type of cancer patients, lung cancer, breast cancer, gastrointestinal cancer, genitourinary cancers, and breast, I don't know whether I counted all, but
rare cancers, including sarcomas.
Yes, sarcomas especially. I should also emphasize that, because these patients, especially rare type of tumors, should be managed in the multidisciplinary setting. And in Acibadem Atakent Hospital, we are able to provide all these facilities for also the rare type of cancers.
I should emphasize that it's not only just treat and cure the cancer. After doing such an aggressive treatment, you need to provide a good functions to the patients to improve the quality of life of the patient. And in our unit, we are very lucky to have that type of supports and separate teams, such as pelvic floor team, to support the patient's quality of life and improve it. So since the quality of the treatment increased, the life expectancy after the treatment also increased. And people and patients are trying to have the similar quality of life that they have before the diagnosis of the disease. And those treatments that we apply, honestly, sometimes has, associated with certain morbidities. Some of the patients are doomed to have a permanent stomach, which means that you need to carry a bag to collect your stool on your stomach. Mm-hmm. So that type of complicated treatments requires complicated care to increase the quality of life. So in such an institution, the patients would also have the opportunity to reach out that type of specific professionals that they can benefit from their advices and support to increase their quality of life and functions.
Most of the time, as a personal criticism for myself as a medical oncologist, you are concentrated on curing the disease or as much as you can. And at the end, you end up with a patient who is free of tumor. And always you're concentrated on what other things, other measures, mainly drugs or medicines that you can give to the patient to keep them in this cured state. But most of the time, we may forget to ask the functional outcomes of our previous treatments. And the patient is happy with the outcome. At last, they are cured of their disease. But they have really many complaints that they usually do not express when you do not ask. So working in such a unit with such a complicated team, so you can refer the patient to your colleague who is going to be more concentrating on the solving of these functional problems which are related with the disease or the treatments that you administer yourself. I think, as you had said, this is the most important area because, most of the time, the patients do not complain about genitourinary disorders. Their psychological problems, the bowel habits and so on. So I think it's really something that affects their quality of life. But of course, they're happy because they are free of tumor, but they need someone to solve these problems. And to have the colleagues included in this area who is eager and who has time to concentrate on such problems is a very good opportunity for such patients.
Also, we know you are working a lot with people from Romania. You are treating them also. How can they reach you?
Well, we have our representatives in different parts of the country, and mainly within Acibadem office, our representatives will be helpful for these patients. They bring their medical files that are available, and then we try to concentrate on both the information provided in these medical files, but also we sometimes have to make some online consultations to see the patient's performance status and to just learn more detailed about their complaints. And afterwards, if there is something to do in, for example, the patient may be just in need of a kind of genetic testing or kind of pathology consultation, this can be provided within the Acibadem facilities, or sometimes the patient has to arrive to our hospital to be evaluated in a more detailed setting. And from the diagnostic process to the treatment protocols, they will be available in our hospital. But of course, there are different ways of connecting us with email and then with phones, but mainly from Acibadem offices, representatives will be helpful in this case.
Also, I wanted to ask, is it true that people from low economical families are more open to have this kind of digestive cancer? Is it true this? Because I read in some articles about this, that sometimes this kind of cancer have people from very modest conditions of life.
It's actually the same for all type of problems, not only specifically digestive type, but especially such kind of pancreas, esophagus, that type of cancers may be much more frequent in the low-income populations. But there are a couple of papers that we also had the opportunity to be part of it, it's general for all type of disorders, especially cancers. So low income, and especially some people, they need to work in a much more, risky conditions in mines and some type of, the chemical factories. That type of places are prone to have more frequent that type of tumors compared to the other population.
There are different factors, I guess. I mean, especially about eating habits. Foods that are high in carbohydrate but low in, valuable protein. This is probably one of the reasons. Eating too much processed meat can be another cause, especially for digestive cancers. But I think it's mainly due to the discrepancies in getting the medical aid in the early diagnostic setting. The patient may be unable to arrive for medical services. And so that meanwhile, the patient's cancer may be progressing. So usually people who are in the low social income are diagnosed in later, more advanced stages, unfortunately.
If you speak about success stories that you are proud of, and maybe you have these kind of stories that highlight the possibilities of your center, maybe you can tell us, because it's interesting.
Of course. There are some stories, not only belongs to me, belongs to all the professionals that we are working about. But from my perspective, at the beginning especially, it's not easy to convince the people to see what capable of they can achieve. And I remember one of the complicated case, which is related to the lady with a recurrent pelvic bone tumor invaded the digestive organs. And I was in the tumor board meeting. Professor Özer was also there. And all the people are saying them, it's an inoperable case. And
I remember that case.
Gonna die in the table if you operate the patient. And I technically was taking to the pictures and looking. I was not experienced. I'm not considering myself like a hero. I'm just a specialist surgeon trying to improve himself in a certain field. But I was able to see the possibility of the operation there, and none of the single person in the room, including the other surgeons who will participate in the operation, was not sure that we can do it or not. But at the end, we were very lucky. The patient was very brave, and she understand that she has no chance but the operation to extend her life expectancy. And we started the operation, and we basically removed the right lower part with the right side of the pelvic bone with the rectum, and created a terminal colostomy and the diastomy and everything. And the plastic surgeon was able to close the wound, and the patient had lived almost 2 years after the operation and died because of another tumor recurrence. And I think from my standpoint, this was the case that I was able to convince the other professionals, even the surgeons, to do such kind of operations that we can do. Because sometimes it's related with make the people see what you see, to convince the people. And sometimes you see wrong way, and then you should also feel that the community is smart as much as you are. But sometimes you need to take some risk to change the practice. And after the operation, we had many tough operations. And I remember to talk and explain what we did to medical oncologists at the middle of night, who called me, why you did this operation. And it's taking time, but step by step, by involving all the team to the work and to the project and care of patient, and having their potential and experience to the treatment, is make many impossible things possible. But it's a time, and it's a tough time, honestly. It's not easy to bear this burden doing this process. But when you do it, and the people around you start to also motivate you to do much better, and I think we are at that level now, and we are moving much faster.
How do you incorporate minimally invasive techniques in your surgical procedures, and what are the benefits?
It's a very nice question, because minimally invasive surgery is a huge area. But in our field, it includes the local excision done by endoscopically and the laparoscopic excision. Basically, we operate the patients, we fill up the gas into the abdominal cavity, in the belly, and we put some special instruments, and we do any operations without cutting the belly. And it gives the patients the benefit to recover faster, to less issue with the wound problem, because there is almost no wound, there's small wounds there. And this is also associated with less pain after operation, which is very important for the comfort of the patient. So minimally invasive operations provided us to do radical operations with a small post-operative morbidity complications, especially wound-related complications. And they improved the quality of the operation, because especially in robotic surgery, we use the instrument. We use 3 arms. We have 2 arms. So robotic instrument provides you 1 additional arm during the operation. And your arm is capable of to turn in 190 degrees. But robotic arm can turn 540 degrees, which is, above human capability. And robotic camera provides you to see the environment 16 times wider than normal. And in open operation, you look the operation field like in a distance. In robot, you can come to 1 centimeter close to the operating area, which is impossible during the normal standard operations. And all those provide us to do higher quality of operations. So this is the benefit of minimally invasive operation. And in certain operations, even can be done by operating surgeon, and assistant surgeon sees nothing, especially in rectum, narrow places. In laparoscopic and robotic instruments, since you use camera, all the world can see what you are doing. And it's also beneficial to train new surgeons by showing how the operation can be done. In open, it's impossible. So those are the benefits of minimally invasive from patient part, from surgeon part, and from the quality of operation.
So everyone should be operated with minimally invasive technique?
No, it's not. I mean, it's not extending the life expectancy, but it's providing comfort and quality during this treatment period.
How do you support patients and their families emotionally and psychologically during their treatment journey?
Well, it is not an easy journey for anyone. It's quite tough for both the patient, the family, the caregivers, and also for the oncologist. Each time you meet with the oncology patient who has been diagnosed with cancer, and you have to just understand what they are really aware of and how open they are to a discussion about their disease. Because I think it's mainly dependent on some sociological and psychological properties of that particular patient. Some patients really do not want to hear too many details about their disease. They're just leaving themselves to your hands, and they want you to decide whatever is the best for that patient. I don't know whether it is the easiest part. I don't think so, because I think it has to be a shared decision with both the patient and the physician, of course, and also the care providers. The family or the friends, whoever are available at that time. And of course, there's a period of denial where the patient does not really accept and always questions why it happened to that patient. Everything was fine, and why at that stage, many questions. But then we want to be patient. We just want to understand what they know about their disease. And we try to give these bad news, especially about their diagnosis, step by step. We try to first explain where the disease has evolved, what the treatment facilities or opportunities are available for that specific type of cancer and for that stage. And we usually try to more emphasize about what we can do for the patient. But of course, we have to be realistic. And it is not very easy, indeed, most of the time. But I think sharing all this news in the first introduction is not easy. And I do not prefer to just explain all these news in the first meeting. First, I just try to meet and try to understand the patient and see whether they have confidence with me or not. Because, you may not really have that good connection with every medical oncologist. Sometimes the vibe is not good. Mm-hmm. It happens sometimes. And so maybe going to another medical oncologist is going to be a better choice for that patient, because they have to trust the doctor in order to get benefit from that treatment. If you have so many questions, and if your medical oncologist is unable to answer the questions, if you're not satisfied, then you shouldn't be there. Because, the treatments that we are administering do always have some side effects. It's 100% we would have side effects, but it depends on that biology of the patient, the dose, the drug that you choose. So we try to explain all these, both side effects and the benefits of that treatment step by step, and to be sure that the patient understands the outcomes. And as I told you, it's not always a success story, but if there is a bond of confidence between the patient and the medical oncologist, it is most of the time it's a success story. Even it is not always cure, but the patient really gets the benefit. So they are open to discussion. They can express their feelings. They can express what they have experienced during this journey. So I really learn very much from my patients indeed. And I'm always trying to hear what they say and what they do not say, of course. And I think it's quite educating for everyone. If you are someone who is just listening to yourself and just, dedicated on the guidelines, then it is not easy to make a personalized story for that patient. And we know that being a medical oncologist, or let's say being a physician, is tailoring treatment for that particular patient each time you meet that patient. But of course, we are not always on the side of emotions. We have to be convincing the patient about the effective treatment protocols with the possible side effects. And it is important to include the patient's family in these decisions so that they will support the patient during this difficult journey.
But what you are answering when you are receiving such questions like, why this happens to me, or everything was good and why I have cancer, because you're not the God, so you can't have an answer. But what you are saying to
I'm
these
saying,
people,
there are different speeches, of course, depending on the feeling at that time. But I usually say it is going to provide no benefit to you to think about why this happened to you. But now a new journey is starting. It's going to be a fight between you and the cancer, and we will fight against this cancer together. We will be beside you. We are on the same side, and we should find the best way to fight with this cancer. It's useless to think about why this happened, but the most beneficial discussion is what is the best thing to do at this time period. Yes. Mm-hmm. And usually I just try to convince the patient focus on that time. Because talking about, long years after, it's not easy, because we know that, for example, we have some drugs that were not available in the markets 5 years ago, which are very effective. And we know that during the last years, cancer has really become a chronic disease. And the patient's survival times are increasing. For example, for colorectal cancer patients, 20 years ago, 15 years ago, it was kind of less than 1 year for a metastatic colon cancer patient median survival. But now we know that it is usually more than 3.5 years, more than 4 years. It's a median survival time. And we have many, many patients living much longer because you have some treatment protocols, you have some different drugs which were not available when the patient was diagnosed. So one of the aims of the medical oncologist is to carry the patient to a period where maybe more effective treatments are going to be available. Like in diabetes, like in hypertension, we are trying to just emphasize on that if it is a metastatic advanced cancer patient, that this is a chronic disease and the cancer treatment is evolving very rapidly and that it is not really good or beneficial to talk about a specific time period. I really do not like talking about numbers of years because every patient is specific, is particular. So they have always their own journey.
Mm-hmm. How do you see the future of cancer treatments and what innovations are you most excited about?
Actually, cancer treatment progressing very fast because it's a complex disease and every cancer has different characteristics. Every day we are learning more about problems and the pathological pathways regarding each cancer type, and this is giving us to create some opportunities to give drugs which doesn't harm other parts of the body. These are the targeted drugs that only focus on the problem and doesn't harm the rest of the body, because current mainstay oncological treatment also has side effects, not only medicine wise, also surgical wise. Simple question: before invention of the minimal invasive operations, you need to cut healthy belly, healthy abdomen to reach out the problematic area. By cutting a healthy tissue, you are creating a second problem to solve another problem. Mm-hmm. So day by day, it's getting more narrow, and day by day, the field of surgery is narrowing, but the importance of multidisciplinary approach is increasing. So in future, there will be possibly less extensive operations for cancer, but every treatment also associated with their consequences and side effects. And especially the targeted therapies are very exciting for me and all the professionals who is dealing with cancer, because they are only focusing on the problem and they are not harming the other parts of the body. And there are some other treatment options, including immunotherapy. Basically, it's providing your immune system to fight against the cancer. So those type of smart drugs, immunotherapy, targeted therapies are very exciting fields that will be improved in future. From surgical wise, minimally invasive operations possibly will be done without cutting the belly. Basically, we will be getting into the mouth or the anal canal and remove what organ we need to do and take out from that area. Mm-hmm. So there will be no incision in the belly. So this type of innovative treatment options will be appearing in the future. I think so.
Yeah, about the medical oncology aspect, it's just been a quite tough journey indeed, starting with the chemotherapy drugs, which do not select cells, tumor cells, but harmful to maybe some other healthy cells of our body. But most of the side effects were reversible, and we only had those weapons 20 years ago, for example. But afterwards, we had that personalized medicine, as my colleague has stated. that you define a specific target in that specific tumor, and you try to target only that gene or only that disorder which is altered. But afterwards, we recognize that we have a big army which is already available in our body to fight with the cancer, our immune cells. And we also found out that tumor cells are quite clever to hide themselves from this immune system army and to present themselves as one of the self or as one of the cells of the body. So the immunotherapy started to develop to make the immune system cells to recognize these tumor cells in a better way and to attack these tumor cells in a more aggressive fashion. However, we know that immunotherapy is not a magical solution for every type of cancer. We are trying to define that particular patient group who is going to get the most benefit from immunotherapy. And we started to end up with some combination trials where you add some chemotherapy drugs to immunotherapies, and so you boost the treatment effect. And also combining strategies with some other treatment protocols, such as radiation, for example. So you make up a more antigenic environment where the immune system is more active against the tumor cells. So combination therapies are getting much more popular. Of course, with the addition of the surgical interventions for more patients has made this journey more successful for the cancer patients. And I think the most exciting area these days for cancer therapies are conjugated drugs, where you combine a chemotherapy drug with a specific target together, and you just send this target to a specific molecule which is expressed only on the tumor cell, and that chemotherapy drug is released only in that area, so least damage to the healthy tissues. This is an important area. And also there are some nuclear medicine therapies. Again, they are using some radio tracers which go and bind to specific molecules that are only expressed by the tumor cells. And they are already being used in the clinics, for example, for the treatment of some prostate cancer patients, for some specific neuroendocrine tumors. And I think they are going to be available for many other cancers in the future. But of course, it is also the development of cancer care is in accordance with development of technology. Mm-hmm. And we have a long journey, but I don't think that it is very far to make cancer really a chronic disease or a curable disease in the future.
What about artificial intelligence? It can help in this kind of treatments, or how do you see how it can develop?
It's developing very fast, and especially in the imaging, in some operating setting, we're already using those technology. It's reducing our failure rates and increasing our diagnostic capabilities, but it's a developing area. And at the beginning, it was expected like improving everything, but there are also lacks related with the artificial intelligence. So especially in surgery, the problems that you may face is countless. Mm-hmm. So if the artificial intelligence has no previous experience with this, it fails. So from surgical wise, there will be surgeons always, mm-hmm. but it definitely will help out to reach right diagnosis fast and do right treatment, less complications.
Mm-hmm. Because you said before that now in Acibadem you have these kind of operations that we can say can change hands of the doctor with more possibilities. Mm-hmm. But also when we are talking about artificial intelligence, it can help to be more fast in like maybe like a human brain.
It is, but if it has
mm-hmm.
an upload before regarding the specific condition. If not, then artificial intelligence stops because it has no counterpart in its memory. And in surgery, you can face this condition every day. Because like every people, we are how many people in the room, we are different, right?
Of course, yes.
So think about our, condition. The disease, has a name, but everyone's disease is like personalities, anatomy, many variances that you realize. And sometimes you do a mistake and patient dies. So this is the real life. So artificial intelligence can facilitate something, but will be the end of journey.
Yeah, I'm still on the side of the believers and where human factor is never going to be neglected, I guess. But maybe because it's due to that our information is limited in that area, and maybe we are not able to see the near future so clearly. But still, there are many variations in handling of every patient. So for the moment, for the current knowledge, still human factor should be included. I mean, but we will see.
We had a very interesting discussion about gastrointestinal cancer, but also we are interested to know what hobbies do you have, who you are when you are not doctors.
Well, I do not have too much hobbies. I'm trying to do some sports these days, yoga, just but for a very short time. I like to, take walks. When I have free time. But so we are so full with working. It's really not easy to spare some time for your hobby. But with the help of my colleague, I'm trying to be concentrating on agriculture, farming, because it is the place where, you are just with the nature. And so you can just deeply dive in your thoughts, just be on yourself and to treat yourself. I think it's, at least my aim is to be developing myself in that area in the future.
To me, I'm a farmer.
Oh,
so
really?
Professionally, how I do the medicine, I'm a farmer. So with my family, especially with my brothers, we are running a farm, and it's very interesting and joyful with me and my kids. And at the weekends, almost every weekend, we are in the farm doing some, taking care of the animals there, trying to do some farming stuff. And it's when you forget everything, sometimes you forget your name. So it helps a lot.
You charge your batteries for...
Yeah, for the next week. And at the beginning of Monday, after the tumor board, it just empties again. So it's very nice to be with nature, and it's very nice especially to take the kids there and to teach them the real life, not an artificial life. And these days have the opportunity to know about nature. So it's some of my life, honestly.
Are your kids attracted by this field where you are? They want also to be doctors, to be oncologists.
I don't think so. But they are, when I tell about some patient, they like, to save some lives. Of course, it's very, good thing when you achieve, but it's very time consuming. I go home very late and leave very early. My time with them very limited. Weekdays almost 1 hour, less than 1 hour. We had the opportunity to be together. We had the opportunity to be together 1 or 2 days at the weekend. So from that perspective, they don't like it.
My son, either he is studying already computer sciences. He chose his area. So he sees us. We're working so hard. We're dedicated. Our life is our job, indeed, most of the time. So, I don't think that, at least my child has decided what to do, and it's not going to be related with medicine.
Yeah.
Thank you for coming here. Thank you for this discussion. I'm sure it's very helpful for both people who listen to this interview, who watch it. So hope maybe next time when you are coming in Romania, maybe we can do another interview about another subject.
Yeah.
So it was a pleasure for me to have you here.
Thank you. Thank you.
Thank you for having us.
You're welcome. Aici se încheie episodul nostru de astăzi de podcast BZI. Am discutat despre cancerul gastrointestinal. Am avut onoarea să discutăm cu doctori și profesori cu renume care au ajuns pe platoul nostru pentru a ne povesti despre cele mai bune tehnologii din domeniul acesta, din domeniul tratamentului cancerului. Noi ne revedem și la alte ediții de podcast cu oameni de la care avem ce învăța și oameni care ne pot inspira. La revedere!
30 years ago in 1991, a small hospital welcomed its first patient in a district of Istanbul, Turkey. Acibadem was the name of that district. Today, Acibadem Healthcare Group is a global brand providing superior medical services in Istanbul, Ankara, Bursa, Eskişehir, Muğla, Kayseri, Adana, and Izmir. Through acquisitions, our footprint expanded to Macedonia, Bulgaria, the Netherlands, and Serbia. In 2012, Acibadem signed a joint partnership with IHH Healthcare, becoming a part of the world's second largest healthcare group. Today, IHH Group is operating with more than 15,000 beds and 65,000 employees. More than 5 million patients yearly visit Acibadem facilities located in 5 countries. To meet all their needs, Acibadem has around 23,000 employees, over 3,000 hospital beds, and spacious service areas designed for optimum healing and comfort. All of the hospitals within the group meet and exceed global standards. Acibadem is well known for its world-class medical centers in oncology, organ transplantation, brain surgery, healthcare, spine surgery, robotic surgery, IVF, sports medicine, and aesthetic medicine. Here, top medical experts using the latest technology join their efforts in a multidisciplinary approach to push the boundaries of modern medicine. Since 1991, the key values of Acibadem Healthcare Group have been patient safety, patient satisfaction, and employee satisfaction. Following these values, we created an ecosystem providing patients with all necessary services at the hospitals. A+ deals with catering, cleaning, and laundry by international standards of service. Acibadem Mobile offers home care and emergency services. Acibadem LabMed renders laboratory services. Acibadem Project Management constructs turnkey healthcare facilities. Acibadem Technology develops and produces software as a hospital management tool. Acibadem University supports the education of healthcare professionals. Every year, more than 50,000 international patients from 96 countries choose to come to Acibadem hospitals in Turkey for their treatments. To provide comfort, trust, and stability to our patients, Acibadem designed Health Point Service. International patients can bring their medical reports to our contract offices and ask for a second medical opinion. Our physicians in Turkey check every report and provide a personalized treatment plan. When patients decide to come to Turkey for treatment, they are warmly welcomed at our Health Point Lounge in airports and transferred to the hospital by Health Point vehicles. At Health Point desks located in our hospitals, our patients are welcomed by translators and supported throughout their treatment journey in 20 different languages. From the very beginning, Acibadem has been known for its medical expertise, advanced technology, and exceptional hospitality. 30 years later, we are here to keep on improving healthcare, touching lives, expanding the knowledge, and welcoming each patient as a dear guest. Excited about the next chapter of our future.